Hi, folks. I'm Dr. Jack West. I'm a medical oncologist focused on thoracic oncology at the City of Hope Comprehensive Cancer Center in the Los Angeles area. And I'm very happy to welcome you to this session on EGFR mutations and management of EGFR mutation-positive non-small cell lung cancer. Just overall welcome to the 2021 Targeted Therapies Forum. By GRACE, Global Resource for Advancing Cancer Education. I also serve as the founder and president of GRACE. I mentioned and introduced myself. I also want to introduce my colleague who's joining us and speaking after me, and that is Dr. Justin Gaynor, who is the director for the Center of Thoracic Cancers and the director of Targeted Immunotherapy and assistant professor of medicine at Harvard Medical School and the Massachusetts General Hospital Cancer Center. The first part of our discussion will be on management of the more common, what we call canonical cancers or canonical mutations, or these are the ones that have historically been the ones that we've focused on in managing managing EGFR mutation-positive non-small cell. So I'm going to talk about current standards and novel therapies for sensitizing mutations, and then Dr. Gaynor will cover the uncommon mutations, and we will also both be able to address questions during the Q&A session for this period. And so we're going to each talk for something in the range of 20 minutes and then hope to have about 25-30 minutes for questions at the end. And I would encourage you to submit those questions using the function on the left side of your screen. I wanted to offer my disclosures here. And I'll start by saying that one of Dr. Gaynor's colleagues in Boston at Harvard and a longtime friend of mine, Dr. Pasiane, was one of the folks who helped led the process of discovering EGFR mutations in about 2004. Before then, we had EGFR inhibitors, and we knew that some patients responded very well to them, other patients didn't. And it also seemed that many of the patients who did especially well had no smoking history, maybe were Asian, women more commonly than men, and we really debated whether there was a need to test for mutations or whether just finding that patients had no smoking history, an adenocarcinoma, which is the most common kind of lung cancer, particularly if they were Asian, if that was good enough to isolate and predict who was going to do especially well with these drugs or not. This trial, called IPASS, was presented and published more than a decade ago, and it focused on enrolling over 1,200 Asian patients with no or a very light smoking history. 94% of the patients on this study had never smoked. And it directly tested Iressa, one of the first generation EGFR inhibitors, also known as Gefitinib, compared to carboplatin and Paclitaxel standard chemotherapy at that time, and seeing which would be better as first-line therapy. And the trial actually did not show a significant difference between the two arms overall, but that's because there were actually two different populations in this study. And you can see this is called a Kaplan-Meier curve. What we have is the change in how patients are doing over time. Time is progressing as we go from left to right. And as the curves go downward, that represents the proportion of people whose cancer has not progressed. So we want to see these lines be upward and stay upward for a long period of time. And what you can see is there's actually a crossover where the patients with chemo seem to be doing better early, and the patients with Gefitinib or Iressa doing a little better later. But when you see this kind of hourglass or tipped hourglass look, that suggests that there's actually two different populations in this study who are doing differently. And then they broke it up into patients whose tissue was available and had EGFR mutations identified or not, and found that they had totally different results. So the patients who had an EGFR mutation, as shown in the middle panel on the bottom, did much better with Iressa, the EGFR inhibitor, and in contrast, the patients who didn't have a mutation did far better with chemotherapy and did quite poorly with Iressa, with the EGFR inhibitor. And so this emphasized that what they saw actually was that 60% of the patients in their study, as Asian never smokers, generally never smokers with an adenocarcinoma, had a mutation. And if you didn't have that, your mutation status was far more important than your smoking status or being a female, never smoker, Asian, etc. All the clinical factors we thought mattered. This changed everything for us because it really highlighted that the mutational status was everything about predicting which patients were going to do better with this. This was the beginning of molecular oncology for lung cancer, and we've had many other targeted therapies that followed that. Now, what also followed were a series of studies that specifically selected patients to go on the study if they had an EGFR mutation. And over the next several years, many studies were done with various EGFR inhibitors. The first four on this table looked at Iressa or Gefitinib compared to chemo. Others looked at Tarceva, also known as Erlotinib, and the ones at the bottom looked at Afatinib, second generation EGFR inhibitor. They all showed very similar results. A much, much better response rate, the rate of the tumor shrinking with the EGFR inhibitors, a much longer time before the cancer progressed, not clear differences in overall survival. And this was really felt that because patients could, in most cases, cross over from chemo to the EGFR inhibitor and then do well after that, you could get to the same place, at least as long as patients got access to these drugs. But in any event, it did become our standard of care to start patients on these EGFR inhibitors, giving them the best chance of doing well up front, because you never know what's going to happen and if people will miss that opportunity to benefit from the best drug for their cancer. Now, it wasn't until a few years ago that we actually saw the results of a study that compared one EGFR inhibitor to another, and that was first-line Osimertinib or Tagrisso, a third generation EGFR inhibitor, versus what was called standard of care EGFR inhibitors, first generation EGFR inhibitors like Iressa and Tarceva. And this study showed a significant improvement in progression-free survival with Tagrisso, that is Osimertinib. That is the yellow bar. And again, in these kind of plots, you want to be on the bar that's on top. Those patients are doing better for longer versus the patients who got what was up to that time still a very good treatment approach of Tarceva or Iressa. This was a global study. And this kind of plot on the left side, on the right side rather, is called a forest plot. This essentially looks at all various different subgroups, different factors to predict whether, to determine whether in one group or another, Tagrisso is better, or in some groups, there's different results favoring one treatment versus another. When this line, this vertical line in the middle represents the drugs being equal. And so when you see that all of the dots, when all of the dots line up on one side, that means that in just about every setting, Tagrisso was better than the other drugs. And in fact, that's what we saw. Regardless of whether patients were men or women, older or younger than 65, Asian or non-Asian, some had a smoking history, some did not, whether patients had brain metastases, whether patients had symptoms, which type of common EGFR mutation they had, and just in every way you sliced it, the patients who got Tagrisso had a significantly longer time before their cancer progressed. It was not until about a year later that we got the results for overall survival. This agent, Tagrisso, did become a standard of care as first-line treatment for patients with an EGFR mutated lung cancer, pretty much after the progression-free survival results. But this really sealed the deal, showing that at the end of the day, more patients were living longer if they started on Tagrisso. Now, part of that was in the second line setting. Tagrisso has been shown to be beneficial for patients whose cancer progresses with what's called a T790M acquired resistance mutation. So why does a cancer end up figuring out how to get around a treatment? It develops acquired resistance, a new mutation, a new adaptation that makes it able to work around a treatment that was previously effective. T790M is a common mutation that develops in patients who get Tarceva or Iressa or maybe Gefitinib about half or a little more than half the time. But a lot of patients will develop other reasons for developing resistance, and Tagrisso doesn't tend to work for that. So those patients did not get that. Other patients, for various reasons, did not get Tagrisso later. And that may be part of why more patients lived longer with Tagrisso upfront. And also, some patients just declined and never got the chance to get subsequent treatments. Another thing that is quite important is that now that we have therapies that can work in the brain and inhibit development of brain metastases, one of the dreaded complications with this, we found that certain drugs work better in this setting than others. And Tagrisso, in particular, a third-generation inhibitor, penetrates into what we call the CNS, the central nervous system, another way of saying the brain, and inhibits new brain metastases. So both of these graphs essentially show that people were going longer before the cancer progressed, they were living longer, and they were less likely to develop brain metastases along the way if they were on Tagrisso. And this remains one of the factors that is very important for us. And so in the past, the factors that we use to determine what we might prefer for one treatment, a preferred EGFR inhibitor, was some intersection of how well it worked, the efficacy, especially if we can know the survival, the side effect profile or tolerability, and somewhat the cost, although these drugs all are priced pretty comparably. Eventually, once we had treatments that could shrink brain metastases, and this also showing that brain metastases were more likely to shrink, this is called a waterfall plot because it kind of looks like a waterfall starting off above the horizontal plane on the left and then going down. Here, the more down it is, the more shrinkage is, and each line represents a different patient's cancer being measured. So what you're seeing is that on Tagrisso, more patients' cancers shrunk, and the only people who had their brain tumor, their brain metastases shrink completely to not being detectable had gotten Tagrisso. Now, importantly, it wasn't like the other EGFR inhibitors don't work. They do work, they just don't work quite as well. And you can see the R's, this represents which patients got radiation to the brain. And so the tumor shrinkage with these medicines is occurring whether patients got prior radiation to those brain lesions or not. And nowadays, because we can be more confident that brain metastases can be treated with a pill-based therapy, we increasingly forego the brain radiation unless we see the cancer growing despite these drugs.